The first step is MOLST ABC, because that will frame your airway, your breathing and circulation interventions, and really change the course of the entire interaction there today. The role that I think EMS has in this space is the goals of care clarification. It's reminding people about those conversations that were already had, getting the documentation, and then really addressing emotion, fear, and concern about the next steps.
What does it really take to deliver truly patient-centered care in EMS? This is the EMS Clinical Brief, where we explore how research, clinical expertise, and patient values guide care, and how quality improvement and culture can shape what's possible. Welcome, listeners, to this episode of the EMS Clinical Brief. Today, we're talking about a topic that is near and dear to my heart, is near and dear to the heart, I know, of the guest that we have today, and I think to many others. And this actually came as a special request from a paramedic colleague I have, Megan Williams, who works out of New York City and also does EMS education, who unfortunately is not going to be able to join us today, but I want to recognize her for saying, this is an area that we need more EMS education on. And typically we kind of dive right into introductions, but I want to start this episode just presenting a scenario and have you start sort of thinking through how you would manage this patient. So let's say you get an emergent response for difficulty breathing, and the patient's a 92-year-old female with shortness of breath who has a history of COPD on HOMO2, atrial fibrillation, congestive heart failure, and hypertension. And you arrive and find this patient poorly responsive, and she opens her eyes to voice, but she doesn't follow commands, has a respiratory rate in the 30s, she's bradycardic with a heart rate of 42 that's irregular, blood pressure of 70/40, and a SAT of 66%, still with that 4 liters HOMO2 in her nose. And when I present this scenario, I think to me, where my mind goes as an emergency and EMS physician is very often I'm immediately jumping to thinking about what's going on with this patient. How am I going to medically manage this case? And I think a lot of our minds do that. But today, I think the question isn't just about what treatments should be indicated in this case, because I think the harder question often to remind ourselves and sometimes to navigate is whether or not all those things that we're thinking about in terms of airway management and blood pressure support and this patient's peri-arrest and what are we going to do about that are actually consistent with what the patient would want, and whether or not those, ABCs of care, what those should look like, because they should differ based on what the patient would want. And so this is just one example that I thought of on the top of my head, but I think we can all think of countless others. And so today what we're going to focus on is talking about the systems of care that exist to help us provide Goal-Concordant Care, which I often describe to my residents and my trainees, and often to patient families, as describing how do we do things for our patients instead of to our patients. And to help explore that topic, I am joined by a person I would say is really is the leader in this field in pre-hospital care, and that's Amelia Breyre. Can you go ahead and introduce yourself?
Yeah, thanks for the introduction. So I'm an emergency medicine physician, and I'm an EMS physician as well. I'm a medical director of the city and county of San Francisco, and improving care near the end of life for those with serious illness for both the patients and their family has been a long-standing passion of mine. And I just, this case that you kind of highlight and opened with, it sounds so familiar. And I think everyone knows this patient and kind of knows this scenario. And, even kind of the way you frame that, I think is great. Taking a step even kind of, back even one more step, I think it's that clinical recognition of this is a patient who is actively dying. And it's one of those things that we take for granted, especially kind of with experience, is just that acknowledgement of, where this patient is today and their trajectory. And that unto itself is a rather advanced clinical skill. It's a palliative care hospice skill, really, that recognition that those vital signs and the way that patient looks today, they don't have much time left. Acknowledging when a patient looks like they have maybe a serious illness, someone who might have some advanced care plan documents. We'll explore that later, but that's just that gestalt, that clinical impression. That is something that, you develop through that exposure, and that already is just, the basis and foundation of all of these conversations.
Agree completely. So I think it's worth delving into some definitions to just make sure that everybody is on the same page. First, what do we mean when we say goal-concordant care? Like, what does that actually mean in EMS and just care in general?
So goal-concordant care is basically the care that you're providing, the interventions that you're offering. Is this what a patient wants? Not the patient's family, but is this what a patient wants? And that kind of important distinction. In medicine, I say there's always things that we can do, not necessarily things that we should do. And goal-concordant care just means the fact that we're giving patients the interventions and treatment that align with their previously stated preferences or their currently stated preferences.
And I love that you started out pointing out the distinction that it's what the patient would want, because we'll talk about the responsibilities of things like designated healthcare agents in this context and why things always really need to be centered on what the patient wants. So we're talking about advanced care planning documents, and we hear terms like advanced directive and living will and healthcare proxy and durable power of attorney and POLST and MOLST and all of those all of the time. And they're all a little bit different. So I wanted to take some time to walk through each one of these. Can you just give a brief overview of what do we mean by an advanced care planning document? And then what we can do is go through each of these kind of one by one.
Yeah, advanced care planning document is kind of the umbrella term for all of the above. It includes a combination of medical orders and legal documents that are all, for a variety of historical and regulatory reasons, really confusing. But, coming up with a term that kind of addresses all of that, advanced care planning documents is what that is. And yeah, the nuances of kind of all of those terms that you mentioned vary a lot, even kind of state to state. But advanced care planning documents, the big umbrella.
So when we say advanced directive, let's dive into those because I think we encounter all of these all the time and they have different implications for legally what EMS can follow and how those documents are used. And when I use the term, advanced directive, I'm including things like the living will or the durable power of attorney for healthcare, or in New York State, that's the healthcare proxy form. Or often I also say like my organ donation checkoff on my driver's license is also a form of advanced directive. Can you define what an advanced directive is and who do those apply to?
I think it's helpful to even take us like one step back and kind of look at the evolution of where these documents came from.
Sure. Yeah.
As they kind of relate to medicine, really. And, the understanding and ethics that surround patient autonomy and self-determination. So, like many things in EMS, the 1960s were kind of where a lot of this stuff started. And that's when CPR was first described. So the first time in 1960s, you have in JAMA that this closed chest massage is this miraculous procedure that's really life-saving. And then, of course, a decade later is the first time you ever hear the term "do not resuscitate" in the medical literature. So, shortly after you have a procedure, you have some thought that maybe it's not for everyone. It's really this recognition that CPR is an attempt to save a life. It's not necessarily a guarantee. And the acknowledgement that that's kind of a reality of this new procedure. And then just some other kind of hallmark items to highlight kind of historically. In 1991, there's the Patient Self-Determination Act, and that basically required hospitals to respect adult patients' right to make advanced care directive and clarify the right of adult patients and their surrogates to make medical decisions. So it was kind of this acknowledgement of that autonomy. And then just a few years after that is when you have the first POLST form. And we can talk a little bit more about what that kind of evolution. But the POLST form came much after kind of these DNR orders. DNR very much was kind of something that was based in the hospital. The reality is when people go home, as EMS so often knows, then what? And the circumstances kind of change. And how do we document patient preferences, not only just if they're having a pulse, not having a pulse and breathing, but even kind of beyond that. And that's kind of the evolution to, from a DNR to a POLST or MOLST.
And you allude and you say this term, like, how do we document patient preference? And that's really like the way that I think about this is very often when I'm teaching about this, I'll put up the chain of survival in cardiac arrest, and everybody's recognized the chain of survival, right? Which is really a representation of the continuum of care of what is standard care in the absence of other information. But I think there's also this other chain, which is like, how do we safeguard and make sure that patient values and goals of care are understood and followed at every stage of this journey as well? And all of these documents that we're going to be talking about are really about that. It's, there's a patient at one point, right, where ideally we have had a conversation that is honest and realistic and talks about what matters most, and we document what those goals and preferences are. But we have to have a way that actually follows the patient throughout the healthcare continuum, which is a really complicated systems of care problem. And because it's so complicated, we'll talk about where the imperfections and opportunities for improvement lie. But that's the way kind of I think about that in terms of what is the purpose of these forms. So I like how you put that in that context.
Yeah, no, I think that's kind of the and, not to jump ahead to kind of the pulse and the power of it, but it is, to your point, like there is so many different intended end users of a POLST or a MOLST. It's meant for a patient to be able to kind of, in plain language, for them and their family to understand. It's meant for those who prepare it, whether that be your primary care doctor or your oncologist, to be able to prompt them to have these discussions. It's meant for EMS, and it's also even meant to some extent for inpatient teams once you're in the hospital. And so how can one form be used for all of the above, be available, accessible, and understood? That's tough. And, people change their mind too. So as people kind of illnesses worsen or improve, how do you kind of adapt and modify? And who, which is also, I know, kind of a big focus of what we'll discuss today too, is who can make those modifications and when.
So let's go back to advanced directives and define what are some of the different types of advanced directives and what is their purpose?
Yeah, so great question. And I think the focus of advanced directives and the most important kind of aspect of them is that they are legal documents. So that means that they are, intended audience is not necessarily EMS as the end user for the most part. Oftentimes in some places, some states, they might need a notary to sign. A lot of advanced directives, one of the major goals of them is actually to identify a healthcare proxy or power of attorney for healthcare. And so, by virtue of that, they tend to be a little bit clunky sometimes. Not the easiest document to read in the event of an emergency. Living wills kind of also can fit into this category. There's some well-known documents such as 5 wishes, which is kind of a version of an advanced directive, and many kind of variations that you might encounter that all kind of fit under this umbrella of legal documents that are advanced directives.
And I think one of the key points about advanced directives is that all of us can have advanced directives, right? It's what I need in advance of having that particular emergency or thing happen. And so that's where, for example, when I have who I designate who my healthcare proxy is, that's me, while I have the decision-making capacity and the ability to do that, designating who I would want to make decisions for me should I not have capacity. And so while today I have no major medical problems or reason that I wouldn't want things, it's still appropriate for me to have a designated healthcare proxy form so that people know who I want to make those decisions. And while state laws have other provisions for people who don't have these legal forms of who makes decisions, right? Very often there's some law saying in what order family members or spouse or et cetera can actually make decisions for people. This is one way that we can go through and make sure that we know who can make those decisions. And living wills are very much the same way. So living wills, people say I wouldn't want these things if this were to occur, but those are not I wouldn't want these things today. It's I wouldn't want to be on a ventilator forever if my brain wasn't working, but that's not today, don't put me on a ventilator. So the term advance is really in advance of the thing happening. And so really anyone who has decision-making capacity, i.e. adults with decision-making capacity, is appropriate to have an advanced directive, which before we get into POLST forms or New York and their special version, the MOLST form is a very different thing because that's actually a set of medical orders that are applicable today. And exactly what you talked about is being able to evolve as patient condition changes, orders evolve with patients, and that makes them in many ways like fundamentally different. One of the ways that is fundamentally different from an advance directive.
That decision-making piece that you touched upon is, I think, so kind of important to understand and kind of frame who is making these decisions and when. And in general, I think of there kind of being three different major buckets of healthcare decision makers. And I think the advance directive is that durable power of attorney identified. And that is just so important because it's someone who the patient identifies themselves when they have that ability to do so. So it tends to be people that do know the patient very, very well. The other scenario, too, is you often see is conservatorships. And that's a little bit more complicated because it's actually court appointed. So, and I think the great example there is Britney Spears, who, she had a conservator that was her father. And there was a legal dispute. She did not want her father to be her conservator. And that was kind of the basis. But I think it just really highlights that conservator that is court appointed may not necessarily have the same aligned interests as a patient. However, they do have the legal authority to make those healthcare decisions. And then the last kind of big category that you kind of alluded there to is the surrogates. So when there is someone doesn't have an advanced healthcare directive, doesn't have a conservator, oftentimes state law might recommend or mandate next of kin, whether that be spouse or adult children or some other kind of alternative hierarchy scheme. But surrogates are also kind of in that category. But I think it's just important to kind of, when you encounter some of these documents, think about who is listed here in making these decisions, the authority that they have, and also their interest and familiarity with the patient.
Yeah. So that's advanced directives, and there's a lot of variability by state law about whether or not EMS can just follow what's an advanced directive in the absence of an order. And so we're not going to be able to say on this, what is the law in all 50 states? In New York State, our policies were changed in 2023, thank goodness, to at least recognize healthcare agents' ability to make decisions for patients in the field in the absence of a form that has documented orders. But things are going to be variable state to state. That's those set of documents. Can we switch and talk about POLST? And I'm saying POLST and MOLST. POLST is the national paradigm, and MOLST because that's what we use in New York State. Do you want to cover a little bit about the history of the POLST and then talk about what is actually included in the national POLST form? And then I can talk a little bit about New York State.
Sure, yeah. So the POLST was first developed in Oregon and in 1994, and it really was just such an interesting kind of collaborative effort between bioethicists and EMS and hospitals. It really was developed to address these issues of portability, accessibility, and honoring patient care across a variety of care settings. So based on the success that the program had in Oregon, there was thoughts about spreading this to kind of other states. And in 2004 was when there was the National POLST Advisory Panel using 6 states. New York was actually amongst the first 6 to be part of that panel. Then now we kind of have this evolution that where all 50 states have some version of a POLST or MOLST or POST. Or there's, I think, a T-pop some states have, and there's I-post, and there's all sorts of variations. Every state kind of has, their own kind of flavor and flair to it. So there is a national form that creates, some guidance, and some states have chosen to kind of adopt it entirely. But there is significant variation in what a lot of these forms do look like, and what each state's law tends to say about these forms and how changes are made to them. I'd say one of the biggest kind of advances in the past decade or two about POLST forms is the introduction of registries. And as we have kind of more health information exchange extending into the pre-hospital environment, out-of-hospital environment, this just has tremendous implications for accessibility and portability and version control. And that's kind of the next chapter in POLST, and having kind of these or MOLST, having these registries and linkage. So more to come on that. I think, like all things, sometimes healthcare can be a little bit slower to adopt than in other fields, but it is kind of exciting to see.
I think the potential is huge, and I think we'll have opportunity to talk a little bit, right? Like Oregon has been the leader, not just in the development of the POLST form, but in EMS accessibility for electronic registries. So like New York, we have an electronic registry that has made a tremendous difference in decreased errors, but it's not yet accessible to EMS. But like this is what our dreams are made of. So in terms of what it is, I think that the key thing for every EMS professional and really patient and everyone in healthcare to understand, right, is that unlike these legal documents, POLST, MOLST, POST, TPOP apparently are a set of medical orders, right? They are signed by a medical provider, and who that medical provider is can depend on state law. In some places it's physicians, in some places it's physicians, nurse practitioners, physician's assistants, but it's a medical provider. And I tell people it's like the equivalent of me having a discussion with a patient about, shared decision making about our plan in the emergency department and logging in a computer and like putting in the orders. And so while this process, I think, as we all know, is imperfect and sometimes isn't followed. And I've had patients be handed a form, right? And they're like completing it on their own and bringing it back, which like makes my head explode because these are truly a set of medical orders. And while we'll look at the form, we talked a little bit how this form is so many things to so many different people and components of the healthcare system. The primary use of this form is to translate conversations about patient preferences and goals into a set of actionable medical orders that those of us in healthcare need to follow, and therefore it needs to be reflective of the patient's healthcare status at this time.
I love that you mentioned conversation because that is the cornerstone of the POLST and MOLST is those conversations that, we don't usually have in EMS or emergency medicine. It's not usually our responsibility on that end. But when we see the form, it should, as best practices, be the product of several conversations with patients, families, and with patients. And so it shouldn't necessarily kind of the content shouldn't be a surprise to the patient or their families for those reasons. And to your point too about like the physician provider signature, as a medical order, oftentimes to be valid, they require a signature from a physician or provider.
Yeah.
And the last component too is I do think is in that patient selection, because it is a medical order. It's not necessarily for everyone. It's not indicated for everyone the same way a medication, needs to be prescribed for someone with an indication. The MOLST and the POLST are only indicated for patients with serious illness, advanced frailty. And that is, what does that mean? It's tough. It's kind of we're kind of where we started for the very, very beginning with that case. It's a clinical impression that, those with kind of clinical experience, when you kind of look at a patient and you're like, wow, like I'm concerned about their medical frailty and their course. And they might be someone who has had a conversation with a primary care doctor, with a cardiologist, with an oncologist about the next steps in the course of their illness. So it's not meant for everyone who's in an assisted living facility. That is not appropriate. Just because you're over 80, not appropriate. It's really for patients who have serious illness or advanced frailty.
Yep. And I think it's kind of like the sick, not sick. It's like, it when you see it. But it also, when we were talking about this scenario, it's like there are certain things that should trigger the question, should I be doing what I'm about to do? Right? Like, is this somebody where the kind of the standard care pathway is for sure going to be line, or is this a situation where I need to pause before I end up doing something that a patient never would have wanted me to do? And yeah, like I have things where they say like, oh, the nursing home requires that they have a POLST or MOLST. Like no nursing home can require that somebody has, right, like a set of these medical orders. I think we should make sure that we have initiated these conversations. And I think there's so much lost opportunity around having this conversation and making sure that those preferences are documented when they exist. But yes, it's a set of medical orders that is applicable today, not in the future, right? Like I don't write in a MOLST form like someday if I have a massive stroke, like I don't want to be intubated. Like that's not, it's like the orders that are reflective of today. I think it's worthwhile actually going through what is covered in the national POLST form. So like what are kind of the big categories of care and how do we interpret those in terms of EMS clinical care? And then I'm happy to go through some of the corollaries in terms of New York, just to kind of highlight what are some of the state-specific differences that might exist and encourage people to go look at their own state form and say, like, when that box is checked, like, what does that actually mean in terms of EMS interventions?
That's a great, it's a great exercise. And, acknowledging the national forum is trying to kind of reach a common denominator, but even then it's tough. I think the universal, though, usually the layout tends to be the same and the content, at least in spirit, is very much parallel. I think the first box, the first category for most MOLST and POLST is the CPR orders, and that's the one that we all kind of know. And you'll notice actually in the national POLST, and you don't see the term DNR there. I do want to just kind of shout out that the evolution away from that language of do not resuscitate is part of this campaign, and it's really these forms, the interventions that are listed here. It's not about taking things away from patients or families, because no one wants that their loved one deprived of something. It's really about putting that kind of positive language to providing that goal-concordant care. So rather than do not resuscitate, you'll sometimes see do not attempt resuscitation, which is kind of a more realistic description of an attempt of something rather than a guarantee of survival. Mm-hmm. And even the more preferred phrasing is allow natural death. The kind of acknowledgement that this is an inevitable course of things, and what you're doing is allowing something that is natural. So by design, you won't see DNR quite so clearly printed on most POLST. But section A, yes, super important, and that is basically, does a patient have a pulse? Are they breathing? And if so, then do they want? If not, do they want to attempt resuscitation, or do they not? And then based on that, if they do happen to be breathing and they do have a pulse, this section doesn't even apply. So move on to this section B, which are the kind of initial treatment orders.
And I think what's important there also is that it's CPR. New York breaks up the CPR orders from the respiratory support orders in a way that's different than the national POLST does. And sometimes it can be pretty problematic and sometimes it's a symptom of not a deep conversation, because people will say, I want CPR, but I don't want to be intubated. But it's like, this CPR is cardio and the pulmonary component of resuscitation. And when I see that, to me, it's a symptom of a conversation that didn't really address what do we mean by CPR, like what does CPR accomplish, and in-depth conversation about what are really the goals of care for that particular patient and what these things actually mean. But I think it's important. It's like when it says CPR, it means like all the things that standardly happen with ACLS if you see that and they do on it, then you do all the things. Importantly, I think it's also, we have to note that you can say you want all the things, right? So sometimes people see that somebody has a POLST or a MOLST form. They have a POLST or a MOLST form, and they act like it's a DNR or DNAR order, and they don't read it. But it can say, I understand that I'm medically frail. I understand that I have medical comorbidities, but it's still within my goals of care for you to attempt resuscitation if I lose pulses. So it's really important to actually read the form, because the presence of one of these forms does not mean that somebody doesn't want resuscitation. It means that there was a conversation had and orders placed around whether or not the patient does.
One of the palliative care PAs at one of the hospitals I used to work at had a T-shirt that said, DNR does not equal do not treat. Treat these patients. Like they still, that first section is only for patients without a pulse and not breathing. And, people might want kind of the full court press otherwise. And that is logically still okay. It's a great point you make. Also about the other interventions too, like what comes through resuscitation is kind of a bundle, right? Like we all know ACLS, but the IOs, like Epi, right? Like the cardiotonic drugs, it's potentially a slippery slope to a central line. So, I think of the resuscitation bundles as all of the above, everything that you kind of mentioned in ACLS. But there is some variation in forms in terms of like, well, what about transcutaneous pacing? And it's complicated to some extent, but I think the way you framed that, well, I think of it kind of as ACLS. that is
Yeah.
resuscitation. And if it's part of that algorithm, then it is not. That's kind of part of this bundle.
It's all the things, and it only apply and that first one is, I think that the situational dependence of that is also really, really important. So looking at kind of the next component, there's the different tiers of care. Can you go through what those different tiers of care and then things I like about the National POLST form is that it kind of bundles the tiers of care. It's similar bundles that I think clinically make a lot of sense. But do you mind going through them?
Of course. So yes, for B, in the initial treatment orders for these patients that have a pulse and or breathing, full treatment is kind of the first one. And I think everybody know that one. That is what that is standard of care. I don't think I need to go through that one.
All of the things I tell people, I'm if that's put me on ECMO for refractory VFib.
Yeah, yes, exactly. Everything, all the boxes checked. So full treatment, I think we can almost skip discussing. And I want to jump down to comfort focused treatment because in some ways that is a little simpler too. The tough one is the selective treatments. So kind of comfort focused treatments, what does that mean? And that is maximizing comfort through symptom management. So that really means, once again, not it's maximizing. It's not taking things away. And when you ever, goals of care clarification questions are something that is very much, I think, EMS clinicians should be having, saying that so you want us to do nothing? That's not the question. Do you want us to maximize comfort? Because if you're given the choice between the two, what would you prefer? Maximizing comfort for your loved one for sure. And really that's kind of emphasizing...
aggressively, right? I will aggressively manage their comfort because people want very often the aggressive options. And I hate the term withdrawal of care. I feel right, I'm not withdrawing care. I am almost caring extra, I am. So I've switched my terminology from withdrawal of care to aggressively focusing on comfort and pain management and all of those things.
Yeah. No, and it makes a big difference in terms of, they're false choices when you say do nothing, withdraw care. Because of course, you're setting up people to say, of course I want something, especially when it's, for their loved one or for themselves. But, I think to emphasize too here on the comfort focused treatments too, sometimes there's just very small touches and minor changes that you can kind of treat with. And it's not about just, leaving someone. But if a patient, for example, is enrolled in hospice, maybe they have an emergency hospice kit, helping family, encouraging them to give those medications that are already prescribed for these indications. Or small things, putting Vaseline on lips, ice chips, fans blowing in their face that kind of can help with that sensation of shortness of breath. Sometimes families and patients, when they call, especially 911, they're scared. And giving people things to do, especially, holding hands with their loved ones, knowing that it's okay, can really make a big difference. A lot of the times it's just reassurance and fear that drives people to call 911 instead of hospice or instead of their prescribing doctor, and addressing and understanding why they called and emphasizing that comfort in kind of those small ways, not necessarily just medication, but repositioning can go a long way. So that's comfort focused treatment. Anything else you wanted to add to comfort focused?
No, and I think from an EMS perspective, right? Very often, you're responding, and when we're thinking about comfort-focused treatment, this is a circumstance where that is checked on a patient where there's already been a conversation about, right, how we're going to manage things at the end of life. Ideally, there's no thing that's 100% true, but focusing on how we're going to manage things at the end of life. In the emergency department, very often, right, I'm having conversations where I'm acutely diagnosing something and then having a conversation about transitioning somebody to a comfort approach. While EMS, right, isn't putting orders in for a comfort approach, I think there's also circumstances where you kind of read the room and the circumstance and somebody actually hasn't had that conversation. And I think that there's value in, as if that patient doesn't have decision-making capacity, they're unresponsive, et cetera, of asking families about have you had conversations about what they would want at this point? I think we've all been in a room. There's like a hospital bed in the living room and there's no paperwork and the person is an extremis. And the answer there, even in the absence of hospice being set up, is not always like do all the things because I don't have paperwork that says otherwise. There, I think there's opportunity, just like I do an assessment to figure out what's going on with the patient, an assessment of prior stated goals is really important because the diagnostic momentum is strong. Like you come in bagging that patient and doing a bunch of things, like that care is going to continue. And you have an opportunity to, even if that patient, right, is transported, and very often they might be transported for symptom management in the ED, making sure that the downstream care is positively impacted in line with those goals. And honestly, like sometimes the critical step that is missed is asking people about what they would have wanted before we do the thing.
Yeah. No, and I think that's kind of brings it back to that case that you opened up with to begin with. It's like you recognize that patient is not doing well today. And the first question is, do they have any advanced care planning documents? Do they have a MOLST? And if that patient has comfort-focused treatment checked off in that MOLST, then I think the conversation is, the next question is, what do we do from here? And definitely transporting that patient is probably not aligned with what comfort focus means in that scenario. In a lot of scenarios, I think comfort focused treatment, if you see that box checked, it means this is probably a patient who might prefer treatment in place. And not always. There's certainly some situations where acute sudden trauma, someone's advanced COPD or cancer, they don't, that broken wrist still needs to be addressed. That is comfort too. So by all means, transport that patient and give them a little bit of fentanyl on the way or whatever your protocols allow. But it's something you would at least think twice about transporting, because this is probably a patient who, based on those conversations, would likely prefer to remain in place.
So let's deal with the messy one in the middle, which is really the hardest, I would say.
Definitely. So saving the stickiest for last, selective treatments. So, there's this language in the national POLST about attempting to restore function while avoiding intensive care and resuscitation efforts. And so, what does this mean for EMS? It means you're probably going to transport them and you're probably going to do a lot of things for them, but it means that it's worth flagging, and especially kind of when they hit the door to the emergency room, that like more conversations are needed. I think that's kind of how I think of this tricky intermediate category. They must have selected it for a reason, and it's probably needs a little bit more discussion as to why. But transport, but do so cautiously is kind of, I think of for this category in the most part.
Yeah. So in New York State, a lot of these are broken up. So in the MOLST form, we have the CPR orders at the top. And then the next thing is respiratory support orders, which are pulled out. And so the first is use all of the things, including, tracheostomy, which is a problem for the ICU physicians. The next one is I would want a trial of intubation, which is also a problem for the ICU physicians, right? Like we manage that and we do invasive airway, including whether or not that's supraglottic airway or intubation or any of those things. The next one is do not intubate, but do a trial of non-invasive ventilation. So let's say I have advanced COPD, I might want a trial of intubation with BiPAP to treat my CO2 narcosis, but don't intubate me if I fail that. And then the last one is like do not intubate and do not use non-invasive ventilation, which, there has to be concordance with these orders, because if somebody's comfort measures only, that should be checked, right? Like I shouldn't be a bunch of respiratory support for comfort measures only as a focus. And then instead of saying selective treatments, they have limited medical interventions, and then you can make some choices about antibiotics, et cetera. But when I see limited medical interventions, very often I'm thinking this is have a conversation. While the respiratory support orders are kind of notoriously difficult to interpret and I think are completed incorrectly all the time, the intent was very good, which is very often in terms of these emergency orders, like I want to know what I do for like A and B and C.
Yeah.
Like what's allowed? And then, if they need a central line for their levo, if it's limited, like somebody can have that conversation, right? If they might need a pacer, somebody can have that conversation. So I like the way that it's generally divided out. But I think even in EMS clinicians, if they see limited medical, there are respiratory supports even within the national POLST orders. Like you should read those. But when you see that, and let's say this is a patient who is in respiratory extremis, but they're hemodynamically stable, or this is somebody who has an acute neurologic emergency, like status epilepticus, I think, in the absence of other information, you do the thing, but you need to convey that this is somebody that you might be having a conversation, and a family is there, and this is somebody who's truly appropriate for a POLST or a MOLST, asking the family to get that information. Because that might be if the family says something like, oh, they wouldn't want to be intubated, and that's somebody I might RSI in the field. That's somebody I might hold off intentionally RSIing in the field, right? And continue bag them and manage that and have a delay till that conversation is actually had and call med control and convey that information. Because very often we think that there's an acute emergency for an invasive airway. And I think very often we can take a little time to figure out whether or not we do that, because we can oxygenate and ventilate people non-invasively for a while if we need to. So yeah, to me, I use the same thing. I say limited medical intervention is a trigger to have more conversation. And I also explain it to that way to patients, is like, this means that before we do something that escalates care, right, that is potentially invasive, it means that we will pause and have a conversation with you or the people you have designated to make decisions. Like that is really what it means to me as a healthcare provider and how I interpret.
Yeah, no, that's really well said. Goals of care conversations is the focus of a lot of palliative care as a specialty. There's like a fellowship training kind of about communications. It's an advanced skill in a lot of ways to kind of have those conversations. And I think emergency medicine physicians do it through primary palliative care. There's that's part of the skill set, and the role that I think EMS has in this space is the goals of care clarification. It's reminding people about those conversations that were already had, getting the documentation, and then really addressing a lot of this is just so much emotion and so much fear and concern about the next steps, and that into itself is a skill. But these are goals of care clarification is really the role that I think EMS clinician and skill set that that's not easy either, right? Like these conversations, they require practice. The same way you've learned how to do IVs and intubations, there's communications training. There's using simulation to kind of get the words right, to kind of practice saying things, to putting, avoiding invasive therapies and maximizing comfort. Like it takes practice too. So acknowledging that this is a skill set.
Absolutely right. Just like death notification, it's a procedure and there's a framework and you follow, and then you kind of mold it a little bit to yourself, right? In the way that you do things. But, in emergency medicine, I think it's one of the most valuable skill sets that we have. And there are so many times where, like at the end of the day, when I go home from the emergency department, the cases where I feel like I did something really good for somebody are not cases where I did a bunch of kind of invasive things without asking somebody what they wanted, but having conversations about what are kind of loving decisions and supporting families and patients at that particular end of life. Like those are the values. And when you get, we don't get that many thank yous in emergency medicine. Like we rarely get cards and things. Like there's not that many thank yous. And I feel like the thank yous that I've gotten in emergency medicine, like most of like the cards and things that patients have sent in or families have sent in are about end of life. They're not about you saved me from a cardiac arrest, or you treated my stroke.
I definitely, my bias too, but I think they are some of the most meaningful interactions that one can have as a clinician are definitely in this space. And, I think without the right tool set, without the right skill set, these can be opportunities for burnout in a lot of ways. When you feel like you don't, aren't kind of communicating or getting frustrated in these very high stress scenarios. But, with this communication skill set, I think the ability to kind of navigate these scenarios, it really is some of the most rewarding interactions one can have. For sure. I also just really love what you said about the that care momentum too. That all starts like with EMS, right? Like that ability to kind of to stop that ICU visit from the beginning. So that care momentum, it's you. So like, acknowledging kind of how important that is.
Yeah. And very often, like, that whole thing can be prevented with taking the time to ask a few questions with kind of like genuine concern for what the patient wants. So like we're talking about the forms and how you interpret them and your legal requirements. But I think if there's one take home, it's like you need to suspect that somebody may have had this conversation in the first place to try and identify some of those things and call into question the next steps so that there's a pause before the train keeps going. So we've kind of hinted about how some of the system as it currently stands is imperfect. And I think anybody who's worked in EMS or emergency medicine is aware of that the system as intended is not always the way it works. Since you've done a bunch of the research on this in terms of protocol variation and how paramedics use POLST, do you want to tell us a little bit about what you learned in doing that research about kind of the barriers that exist and how do you think that we should overcome them, including, if possible, like actionable things for some paramedics to do or EMTs to do while we try and fix the system?
For sure. So, I would start by saying that how good is EMS at using the POLST? One of the studies I did basically concluded that there's some room for improvement, especially around patients who select that limited intervention. It's confusing. So I think that in particular, people don't know quite what to do with. So I think that can be really a focus of training, and especially kind of around the POLST and having those goals of care clarification discussions. And then the other kind of major research project that I took on in this space was looking at the national variation in what different types of DNR protocols looked like for EMS, looking at a lot of major cities and states. And basically, about 86% have a specific DNR protocol. 50% still permit the use of advanced directives, 13% use living wills, and 76% kind of explicitly mention the POLST or portable medical orders. I think the trend towards the POLST and the MOLST is really the way to go, because I think these are well designed for EMS in mind. But obviously, there's heterogeneity in that. So that's, I think, where things are trending. And then certainly with the use of kind of e-registries and more digital versions, it's an exciting time to kind of see what effect that might have in actually how powerful it can be in terms of getting patients the goal-concordant care that they document.
Yeah. And so I think, if I were an EMS clinician at home thinking about this, it'd be actually looking at the form, right? And kind of thinking about different scenarios and saying, if this said limited medical interventions, how would I navigate that? And I think the advice on how do you navigate that is often you think, how do I get more information? It's like how do I question, like, what am I about to do and make sure that it's in line with patient wishes? I agree. I don't think it's just EMS clinicians who have a hard time navigating limited medical interventions. It's all of us. And because really what it is a prompt. I mean, it's so situationally dependent about but it should make us question. We need to have a conversation with somebody before we do something that is potentially invasive or painful with the goal of prolonging somebody's life that way. And I would say the second part of that is be brave to start having conversations with folks and think about how you can get more education. As a medical director of a paramedic program, we do these types of scenarios. All my students read the book Being Mortal because it literally changed how I practice medicine when I read it as an emergency medicine resident. But I think anybody has an opportunity to learn more about that. And I think your family is a good place to start having these conversations, because sometimes we're like, well, I don't know, I might say the wrong thing with a patient. But like, go have the conversation with your mom or your dad or your uncle or something, because navigating those conversations and having feedback from people who are non-medical, it only stands to benefit having these types of conversations with folks, but it's a good place to start kind of getting words and see how they received and being a little brave about having these conversations that I think reap a lot of benefits.
I 100% agree with that. Just starting on a personal level too. It's having those conversations with your own loved ones, your grandparents, your parents, aunts, uncles, those, whether they're seriously ill or not, understanding their preferences, their goals, what is quality of life for them now and how that might change is really, I think a lot of what we learn in medicine and what we can bring home is just really powerful, and it's a really, really great place to start. Is sometimes making this a little bit more personal. But thanks. This has been just a wonderful conversation, and what a great topic, Maia. Thanks for the invitation.
All right, so before you go, let's revisit this case. So to remind everybody, we've arrived. It's a 92-year-old who is on HOMO2, has AFib, has congestive heart failure, and is poorly responsive, not following commands, respiratory rate in the 30s, bradycardic, hypotensive, and markedly hypoxic. So you're in that circumstance, and I think, right, people are like pulling out their supplies, right? They're pulling out their BVM, they're doing all this. How do you approach this case, Amelia? How do you think about preparing for interventions while identifying whether or not those interventions are indicated?
So I think the first step is MOLST ABC. So identifying, is there any advanced care planning documents available to review? Because that will change and frame your airway, your breathing and circulation interventions, and really change the course of the entire interaction there today. And then also understanding who is in the room right now. Was this, in this particular case, who called? Was it?
Yeah.
Was it a patient's loved one who was scared? Was it a nurse at the facility because this was policy? Understanding, the nature of the call and why. It doesn't take, I think, too much to get to the bottom of that. Will really just also frame those next steps in terms of, if this is perhaps a hospice patient and it was family that got scared, then really what needs to be done here is address the fear, address the concerns, and kind of take those steps from there. The actual procedure in ABCs, seasoned EMS clinicians, you got that. But the ability to pause before jumping in and kind of assess the room, and assess kind of the patient's preferences if they have them available, whether that through a designated kind of surrogate decision maker or through documentation is really, really a priority.
And, and sometimes we don't have all that information right away, right? So let's say I'm in a facility and the patient's daughter is the healthcare agent and the decision maker, and somebody has to go get the paperwork. I think about how do I proceed by the least invasive route to maintain things, right? So while I'm trying to figure out, right, I will start oxygen. I might do bag mask ventilation while somebody is getting me the paperwork, but I will not proceed, right? I mean, I'm not going to intubate this patient anyway with no blood pressure and no SAT, right? But I will proceed, honestly, by the least invasive route while I am collecting that information, while prioritizing that information. And this is a patient that sometimes people feel compelled, we should stay on scene and do this resuscitation. But I've heard this patient was really sick. We just left the facility and started resuscitating in the ambulance. And I'm like, first, we should stay on scene and resuscitate this patient regardless. But also the worst thing we can do when we have a sense this person might have an advanced care planning document is leave the facility before we've identified that they have an advanced care planning document. That's like leaving with your stroke patient and not asking a last known well. Right? That's going to determine the rest of the care. And so prioritizing that information, you can think of all these different scenarios. You're at a nursing home, you're at an assisted living facility with somebody else who call, you're there with the family decision maker. And I usually, will initiate just like I'm getting a history of what happened when they developed their shortness of breath. I will add in questions about, have you had conversations or do you have any document? I'll say something like, she is really sick. I believe she might be actively dying before I move forward. Using those words, did you have conversations with her? Or do you have any documents about what she would have wanted? And sometimes they're like, I don't know. And in New York, I'm like, do you have the pink? Is there a pink form, right? Or is there a photocopy of a pink form? But it's really this. Sometimes the first inkling that you get is they say yeah, we had those conversations. She said she didn't want to be on life support. That, and you have to translate and navigate that. And so I tell people it's not the end of the world if somebody gets, like 3 minutes of assisted ventilations while we figure out this information. But I think it's really bad if this patient gets a bunch of invasive stuff, gets carted, gets a bunch of ventilations, codes in the ambulance, gets a full resuscitation ROSC, and shows up on vasopressors, intubated and resuscitated when that's something they didn't want, and like ending up in the ICU and later on. And those things happen. And I think we traditionally don't. I think very often we think of medical errors in terms of like, I made a medication error or I missed this diagnosis. But I think doing things that a patient didn't want is actually a grave form of a medical error. And so like we should be thinking of in that system. And just like I'm going to double check the med that I give the patient, I should double check the intervention when I get a sense like, and sometimes we don't have it, right? But we should at least pause and think about it.
I think there's a lot of medical legal fear about not resuscitating someone who should be resuscitated, but I do think there's also equal parts wrongful life patients who were resuscitated, but that is not what they wanted, and that is not what their documents might have shown, and there's harm in that too. So. Reviewing these documents, having that kind of conversation, that quick clarification goes a long way in providing that goal-concordant care.
Yeah, absolutely. Thank you so much for your time. You're one of my favorite people to talk to. So it's such a pleasure.
Feelings mutual.
Until next time, everybody.